Ladies and gentlemen, it's my great honor to come to Changchun GW-ICC again. So my assigned topic is normal anchoring transfemoral TAVR device for aortic regurgitation. So as earlier speaker said, increasing incidence of chronic AR with age, particularly when age more than 70 years old, you have annual incidence about more than 2%. If the patient is symptomatic, mortality will be increased to almost 9% per year. If the patient is with NYHA class 3 and 4, mortality further increased to about 25%. You can see this graph. So as we all know, aortic regurgitation is different anatomy with calcified aortic valve stenosis because they have minimal or absent cuspous calcification. They have dilated aortic roots. Also, they have frequently they have coexisting of dilated ascending aorta, so-called aortopathy. So this is the implant current on market off-label use devices. You can see if you don't carefully select the size, like earlier speaker talked, you may have valve migration. Even you place the second valve, you still can cause this kind of result. Clearly the insufficiency anchoring dislocation valve emboli mainly driven by large annuli and a concomitant aortic dilatation. Therefore, this is the current newer generation TAVR devices result for pure AR from the reported journal. You can see, although they have a really beneficiary compared with earlier generation, but the device success rate is still low. 74% clearly is much worse than Guangyuan's result, and a high rate of secondary valve and a high rate of PVL, and also pacemaker rate is high, and many cases converted to surgery, so you need a surgery backup. Therefore, they have a high 30 days mortality. So here is therefore we need a dedicated valve, which is anchoring. Now we have a balloon expandable, we have a self-expandable. Most is target aortic stenosis because you have an anchor, so-called calcification. For without anchor, purified AR, you have to get a docking system to anchor the valve there. So here is the J valve, which is domestic valve. I'm sorry. So the J valve is designed to treat AR and AS situation. It's approved valve transapically, and in over 5,000 patient experience, it's domestic manufactured valve. So this is the Bo1 leaflet valve with anchor ring, and here's the delivery system, and this is the valve unique feature. I will not repeat it from here, though we all can see that. This is the pretty unique size matrix. You can see for large annuli, particularly you have 31, 34, which is fits for the parameter, 91 to 95, 97 to 105. It's quite big. If you use oversized self-expandable valve like this kind of annuli, you always need to worrisome the valve migration. So beside that, because they have anchor ring, which is auto commissure alignment, suitable for low coronary and also suitable for in future coronary re-engagement and valve. So here is ladies and gentlemen, I report the first North American compassionate use experience, which is presented at CRT this year. It's about 30 patients, and within 5 hospitals. I went to the Crystal Hospital a few times. So include St. Paul, Vancouver Hospital, include the Methodist Houston Hospital, and Harrison Ford Hospital and Toronto. So here's the patient demographic. You can see the age is pretty old because compensatory use, and class 3 and 4 about 95%, 96%, and annular parameters in average 81. You can see earlier speaker talk about the inner valve is about 38% over annular size over 85 millimeter, which is exclusion criteria for align AR, which is the inner valve. So here is you see the calcification situation. Almost more than 80% is non or mild calcification. So here is the severe regurgitation, more than 90%. So this is a flow chart of patient included to this study. And here's the implant J valve sequentially. You have same thing, you have aortic angiogram, coplanar view, and then insertion this, because it's a two component, it's very trackable and flexible to do the deploy. And then you put placement, the anchor ring, deploy the valve. Now we require fast pacing, but you do, if you don't need fast pace, but fast pacing is always good. Here's the valve post implantation. This is a case almost horizontal aorta. So for J valve still is doable. This is the case. Follow the same sequential. You can see you do the aortic angiogram, and you can see huge regurgitation, and then anchor ring release is stepwise. You do release the anchor ring. When the anchor ring go into the 3 cuspus, you do the double check, make sure the ring is in the cuspus, and then you release the valve, final angiogram. This is the compensatory use clinical result. You can see very good hemodynamically within immediate result under 30 days as well as 1 year. So you can see MIH classification. You can see definitely majority of cases will be lower. I'm sorry, this one. And then you also can see aortic regurgitation severity dramatically decreased, patient function better. This is the North American compensatory use registry conclusion, the first North American J valve TAVR experience in patient at perhaps or high risk surgical risk patient was performed with higher success rate, and clearly they have some learning curve, and should be acknowledgement this compensatory use. Device failure during the early 2 years, 12 patient experience promoted device iteration and a change in anatomy enrollment criteria, despite clinical and anatomical risk profile of the study population. Serious complication to 30 days were not found infrequent. And then J-valve provide excellent acute and 1 year result, which is no AR more than moderate at 30 days, mean gradient less than 10%, 10 millimeter mercury. J-valve safety, efficacy, and successfully treat patient excluded from either trial from the inner valve. So here's a couple of cases. Example from China trial, because China trial enrollment is so quickly, within 5 months, enrolled 142 patients. And here's one case. You see the annuli is 85 parameter driven, and then you can see the sinus valsalva, and then the LVOT 91, and then it's not horizontal, but this is the deploy procedure based on. You can see coplanar view, huge regurgitation, anchoring. It's pretty easy. Also, a couple of minutes if you select the right patient without any challenge patient. It's easy to do. And because this kind of anchoring, when you go to commissure, it's automatically engage the sinus. It's distinguished with the inner valve. They have pointer. You need to really rotation the device. This device, you don't need the rotation, just the push, because this, this kind of this kind of design. So here is the final result. Here is the second case. It's a little horizontal. You can see the aortic root dilate, dramatic dilatation. This is the, oh, I'm sorry, go back. Here is the annular parameter is 86 almost. And then this is the deploy. So clearly you needed to do the coplanar view, the injection, anchoring, and then, oh. And then this is another case, same large annuli. Because I will report the large annuli over 34 millimeter devices this year TCT, so I didn't include in this presentation. But we do have a tremendous case as large annuli. Same result. So here's the, ladies and gentlemen, this is conclusion. Device therapy for pure AR is an unmet clinical needs. I mean, dedicated device. In the current on-market AR device do have some anatomy. If you pick up the right anatomy, it's fit, as the earlier speaker said. The clinical outcome use off-label TAVR device for pure AR still unsatisfactory. With anchoring fixation mechanism, J-valve treatment of pure AR can grasp the native leaflets and align properly to the native aorta anatomy. Further clinical evaluation of transfemoral J-valve is underway. Thank you for your attention.